Uh, Good afternoon, everybody. My name is Dr. Ifatu Oranusi, and I'm the Secretary of the Education Committee of the Nigerian Society of Anaesthetists. And I'd like to, on behalf of the President of the Nigerian Society of Anaesthetists, Dr. Busola Briggs, and the Chairman of the Education Committee of the Nigerian Society of Anaesthetists, Professor Hassan Deti Muhammad, I'd like to welcome us all to the second session of the 7th webinar series of the Nigerian Society of Anaesthetists. Today we have an interesting topic and with two very qualified presenters. The topic for today is essential emergency and critical care, strengthening critical care services globally. And to moderate the webinar for today is no other person than our own Dr. Irene Akideno. She's the head of the Department of Anesthesia and Intensive Care at the Iro Specialist Teaching Hospital, Edo State. And also she is the General Secretary of the Intensive and Critical Care Society of Nigeria. And at this juncture, permit me to invite Dr. Irene Akideno to take the floor and lead us through the proceedings for the webinar today. Dr. Akideno, please. Dr. Akideno, you have the floor.
Thank you very much, Dr. Ranusi. I'm Dr. Irene Akideno, and I will be moderating this session. Good evening for those joining us in Nigeria, to all for the attending this webinar series. It's on essential emergency critical care, and we have two speakers. The first is Dr. Anna Marie Crawford. She's an associate professor of anesthesiology and critical care medicine at Stanford University. She also holds an honorary associate professor position at the University of Rwanda. Dr. Crawford founded her department's Division of Global Health Equity in 2011 and currently serves as the Director of Global Engagement Strategy. She has a passion for global engagement as a way to strengthen reciprocal professional development, global community, and equitable healthcare access. For over a decade, Anna has worked in medical education. I would say she's really passionate about it, primarily in underserved and variably resourced areas to promote systems change and quality improvement. Dr. Crawford also chairs the California Society of Anesthesiologists Global Health Committee. She serves on the WFSA Education Committee and is the lead for the Essential Emergency and Critical Care Training Working Group. She has served as a consultant to several non-profit organizations, the WHO and the Lancet Commission for Global Health. She's the creator and editor-in-chief of the Global Anesthesia and Critical Care Learning Resource Center, the LRC, an online education platform offering free and open access resources for healthcare providers. This was very key, especially during the COVID-19, and these programs have reached over 8,000 learners from 145 different countries. Anna believes global includes local. She's also working in her local community to address social barriers to health. As the proud recipient of the 2021 Kevin Mallott Humanitarian Service Award, Dr. Crawford worked with the Pine Ridge Native American community in South Dakota, assisting local teams preparing to care for critically ill patients with COVID-19. I would also give a brief bio on Karima. Dr. Karima Khalid is a lecturer, researcher, and consultant in the field of anesthesiology and critical care, holding positions at Muhimbili University of Health and Allied Sciences and the Muhimbili Orthopedic Institute, respectively, both in Tanzania. With a keen eye for identifying gaps in her field, she is driven to seek practical solutions to foundational problems, making significant advancements in the field more tangible. Karima's passion lies in addressing the fundamental aspects of critical care using the innovative approach of Essential Emergency and Critical Care, EECC. As a key member involved in the development of EECC from its inception, she has actively contributed to research around it and the dissemination of its findings aimed at improving quality of care to critically ill patients. Her involvement in the case management pillar of the Emergency Response Committee of Tanzania's Ministry of Health played a role in the formulation of the country's EECC strategic plan and the Oxygen Plus guideline, which integrates EECC principles. She's deeply committed to capacity building initiatives in the perioperative and critical care space and has made significant contributions as the country lead for the WFSA obstetric and pediatric courses, as well as through her directorship of VAST courses. Furthermore, she has played an instrumental role as an anesthesia lead in the Surge Africa project as one of the program leads for the ESTA program, focused on enhancing capacity in obstetric and neonatal care, as well as in leading the ISDB Gradient Health Initiative of building capacity of non-physician anesthesia providers through mentorship. Karima is also passionate about utilizing simulation-based training methods and is currently exploring into strategies to incorporate simulation into the assessment and enhancement of the quality of EECC. By incorporating this approach, she aims to further elevate the standards of care and advance the field of critical care in meaningful ways. Karima has previously served as the treasurer of the Society of Anesthesiologists of Tanzania as part of her commitment to contributing to the advancement of the specialty. It is indeed my pleasure to introduce and welcome these two passionate researchers who are keen educationists and very passionate about essential emergency critical care all over the world. Our first presenter will be Dr. Anna Crawford. You're welcome, Anna.
Thank you. And thank you for the warm welcome. Just want to say, first of all, that it's an absolute honor to be here with all of you today. Looking through the list of participants, I see a lot of friends, which makes me feel even more excited to speak to you today. And I just want to give special thanks to my dear friend, Dr. Dati, and also to Karima Khalid. I think it's an honor to present next to her. As mentioned, we'll talk about essential emergency and critical care. I'm Anna Crawford. I'm an anesthesiologist at Stanford University. We're going to start with talking about critical care, and then we'll talk about essentialness, what that means. We'll also talk about critical care combined with essentialness, which is essentially the definition of EECC. And then we'll talk about the evidence base around. Okay, we're going to start with a case. We have a pregnant mother, 40 weeks. She has a seizure at home and arrives to the hospital unconscious. She's diagnosed with eclampsia. She has an emergency cesarean section, and a healthy baby is delivered. After surgery, a diazepam infusion is started for her seizure. Unfortunately, she dies on the ward overnight. So why did this woman die? Did she have a blocked airway? Did she bleed and become hypotensive with shock? Were her vital signs checked? Was there a provider on the ward? Why did this woman die? So the context is that this case is not uncommon. We see this not infrequently. And part of the context is that for decades, we have been advocating to increase access to healthcare. But this case is a good demonstration that we also need to advocate for higher quality of care. There's a Lancet Global Health Commission on high quality health systems that found that poor or inadequate care is common across many conditions and across many settings, and it may actually be a bigger problem than access to care. They also estimated that if we could improve the quality of health systems, we could actually save over 8 million lives in low and middle income countries. And in order to determine how best to do that, we need research to transform these low quality health systems to high quality healthcare systems. So disparities in health outcomes continue to shock. So as demonstrated by this case, women in sub-Saharan Africa who undergo an emergency cesarean are 50% more likely to die, as are all surgical patients in these resource-constrained practice settings. Critical illness is the most severe form of illness. Unfortunately, it doesn't fit in one category, it fits in all categories. So critical illness doesn't care if the patient is a mother or a child, an adult or a pediatric patient, and critical illness doesn't care if it's a surgery patient or someone with an infection or somebody with a non-communicable disease. Critical illness has had apologies, I'm not sure how this drawing is being put on the slides. I don't know if the host can remove this. That's not me annotating here. I don't know how to remove that. Okay, so historically, there have been multiple attempts at creating a definition of critical illness, but we like this one that was formed in July of 2022 that states critical illness is a state of ill health with vital organ dysfunction, a high risk of imminent death if care is not provided, and a potential for reversibility. And I think the potential for reversibility is a very important point, because that actually is an opportunity for us as providers to intervene in the critical illness and perhaps change the course of that patient's decompensation. The burden of critical illness is also hard to define. If you look through the literature, many people will use metrics such as the amount of ICU resources utilized as an example of the burden of critical illness, but this is obviously impossible when places don't have ICU resources. Additionally, sometimes the burden of critical illness is attempted to be defined by the diagnoses, but oftentimes ill patients are not even recognized. So we have some attempt at defining this burden, which is often underestimated. So we can use some certain diagnoses to kind of estimate what our burden of critical illness globally may be. And we know that there are 11 million annual deaths due to sepsis. 45 million adult critical illness cases occur annually. 7 million children in low and middle income countries each year need oxygen due to pneumonia. 1 in 10 patients in the emergency unit are critically ill. And in-hospital prevalence of critical illness is somewhere between 12 to 18%, with a mortality of 15 to 30%. So you can see it's near a quarter of patients may have critical illness in hospital. With the COVID-19 pandemic, 20% of COVID patients became critically ill. So this is a large portion of patients that would need critical care in a time critical manner. And now, as of today, I believe close to 7 million people have died of COVID-19. Critical care also needs a common definition, and we like this one, also put together in that same publication in July of 2022. Critical care is the identification, monitoring, and treatment of patients with critical illness through the initial and sustained support of vital organ functions. So in order to provide critical care, it needs to be time critical. We need to be able to identify the patients, monitor them, and do the first step treatments to reverse potential decompensation. So critical care is the care of critical illness. Where are the critically ill patients? As mentioned previously, the critical illness occurs anywhere. It can occur in any type of patient in any location. So we see critically ill patients in emergency rooms. We see them on the wards. We see them in the operating theaters, the HDUs, the ICUs, and even in the community. In patients that are in hospital, most critically ill patients are actually cared for on the general wards. And this is true in both high resource settings as well as resource constrained settings. So you can see that 97% of critically ill patients in Malawi were found to be on the general wards, and it was similar in Sweden, where 94% were found on the wards. So most critically ill patients can be found anywhere. It can also happen throughout the patient's life course. So again, critical illness happens regardless of age or gender, whether you're a mother, whether you're an elderly, adult, or pediatric. So there is a large gap in the amount of critical care that is provided versus the need. In pre-COVID times in Kenya, only 58% of beds in hospitals had oxygen. In Malawi, 90% of hypoxemic patients did not receive oxygen at all. Lack of staff, lack of infrastructure, lack of protocols and guidelines, and lack of training for basic emergency and critical care in hospitals in Tanzania and Sierra Leone has been found. The World Bank's disease control priorities found substantial deficiencies in emergency care in many parts of the world. During the COVID pandemic, it was also became evident that even in high income countries, there was disparity and inequities depending on location, and some places actually ran out of oxygen in those countries as well. So our first take-home message is critical illness is common. There's a substantial unmet need of critical care in hospitals, and critical care is neglected and under-prioritized. So why is there such an unmet need of critical care? We tend to put our patients into silos. This is a surgery patient, or this is an obstetrics patient, or this is a pediatrics patient. But again, critical illness happens to all patients in all locations. Critically ill patients also fall in the gaps between initiatives. So we have global surgery initiatives, we have comprehensive emergency obstetrics and newborn care, we have integrated management of childhood illnesses, emergency triage, access, and treatment. We have all these different initiatives, but they focus on very specific patient populations where, again, critical illness and therefore critical care are cross-cutting. We need more advocacy for that unmet need. We need a unified approach for managing critical illness. And we have a lack of focus on the essentials in critical care. And I think a lot of that lack of focus is because of the distraction that we focus more on ICU level care, we focus more on technology and innovation, and that really leaves behind the essentials that are needed for all patients. So depending on the settings also, and the time of day, patients may or may not receive the care that they need. So when we have big differences in resource availability amongst district hospitals, regional hospitals, and tertiary centers, and then we also have a difference of resources during the day or during the night, the critical care and ICU care or the critical care may not be available for patients. And again, we just want to stress that critical care is not ICU care. It's time critical care, and that can occur anywhere. Again, a representation that essential emergency and critical care is cross-cutting. It occurs in any location, and it's the very fundamental essential care that all patients should receive everywhere. So it's the ability to identify a patient, it's an ability to monitor a patient. It's the ability to provide oxygen or fluids. And it's not necessarily the ability to do more advanced level care, such as vasopressors, renal replacement therapy, mechanical ventilation, et cetera. EECC is this essential fundamental care that should be provided to all patients in all hospitals across the globe. It's good to think about EECC as a concept and systems innovation. So rather than an innovative piece of equipment or a new medication, it's really an innovation across systems. So EECC is the most simple first-line form of care for critically ill patient. It's the care that all critically ill patients should receive in all hospitals in the world. And it is provided to all patients irrespective of gender, age, diagnosis, or social status. We use the word essential or essentialness in the same way that the WHO lists the essential medicines list. So these are the essential medications that should be available in all hospitals around the world. And similarly, EECC is the essential care that should be available to all patients around the world. It's the prioritized first-tier standard of care. It's the standard of care for critically ill patients. It's low cost, it's feasible to deliver. It effectively addresses important health threats in the population, and it should be delivered to everyone. So when we say essential or essentialness, that's the EECC, or the essentialness of critical care. So how did we come up with EECC, and how do we define what is included in EECC? The EECC network leaders essentially compiled 296 clinical experts from all across the world. And you can see on the map the countries that were involved. You can also notice that this includes high-income countries, middle-income countries, low-income countries. So EECC really is designed not only for low and middle-income countries, but for all the disparities that occur for critically ill patients in any country in the world. But of note, 67% of those included in the cohort were from low-income countries. And the clinical experts were from emergency care, intensive care, medicine, surgery, pediatrics, obstetrics, et cetera. And it included physicians, nurses, and other types of care providers. And what they decided through this Delphi consensus is that they came up with 40 clinical processes that should be included in EECC. And in order to activate or provide these clinical processes, there were also certain readiness requirements that hospitals should have. So again, there's 40 clinical processes, for example, triaging, identification of emergency units and wards, oxygen treatment, et cetera. So part of the clinical processes is the identification of critical illness. So in order to identify a patient as critically ill, we need certain things. We need to be able to assess vital signs. We need to know how often to assess vital signs. We need to know what to do if the vital signs are abnormal. So we need to be able to triage when critical illness is recognized. And we need to have that available for all patients in all locations at all hours of the day. Once we have identified critical illness, we also need to provide care of critical illness. And remember, this is the first step, fundamental, essential provision of things such as relieving a blocked airway, providing oxygen or breathing support for patients, giving intravenous fluids and stopping bleeding when circulation is compromised, and then also providing care for reduced levels of consciousness. So whether it's putting someone in the recovery position or treating hypoglycemia, keeping patients who have seizures away from harm. These are very fundamental, basic care that should be provided when these patients are recognized. Again, in order to provide this level of care, the hospital has to be ready. So what does the hospital need? The hospital has 66 readiness requirements. And this includes equipment, consumables, drugs and routines such as protocols, policies, guidelines, and then also the infrastructure. So an example is a pulse oximeter and probe, the health workers that are available, the health workers that are trained appropriately, and designated infrastructure, space, and areas across the hospital. Also, when you're providing care of the critically ill patients, we need things such as oxygen, a suction machine, a bag and mask for ventilation. These are the requirements that must be available in hospitals for the providers to give the best essential care. So if we could scale up EECC so that it was provided to all patients in every health facility in the world, how many deaths could be averted per year? If we make some basic assumptions, we can look at the number of critically ill patients per year. we can look at the current mortality rate versus the estimated decrease in mortality rate when EECC is provided. So we think that EECC is provided around 80% of the time in higher resource parts of the world and 20% of the time in lower resource parts of the world. If we have a mortality reduction in the higher resource half, that would then be 20%. And in the lower half, it would be 80%. And we think that that reduction would go down from 24.5% to 22%. So ultimately, providing EECC in every country across the globe could potentially avert deaths of approximately 1 million. There's an uncertainty interval, whereas EEC only averted half as many deaths, so that would be around 500,000. But if it averted twice as many deaths, it could go up to 2.1 million. So either way, we think a significant number of deaths could be averted if this fundamental essential care were provided. Let's go back to our case. We have the pregnant mother with eclampsia who's unconscious. She's identified as critically ill. So rather than being sent to the ward with a diazepam infusion, she receives EECC, where she's monitored, where there's a bedside provider, where her vital signs are checked, where her level of consciousness is assessed, and this patient then survives. Our take-home messages: critical illness is common. It goes across all patients in all locations. There's a substantial unmet need of critical care in hospitals, and it's been neglected. For real-world impact, all hospitals should prioritize the provision of low-cost, cost-effective EECC, and we have a large potential for averting deaths. And with that, I'm going to hand over to my colleague, Dr. Karima Khalid. Thank you very much.
Thank you, Anna. I'm going to share my screen. Hi, everyone. Dr. Karima has been previously introduced from Tanzania, and I'm an anesthesia and critical care consultant working at Muhimbili University and Muhimbili Orthopedic and Neurosurgery Institute here in Tanzania. And I'm very happy to be with you. Thank you for the invitation, Dr. Dati. And I've met a couple of people like the president, Irene herself, Professor Dati, who I highly respect and admire. And I'm really happy to be presenting to you EECC today together with Anna. So I'll take it from the second part of this presentation, and I will be talking more on what we have done around EECC so far. So just to remind you, maybe what Anna has just said right now is that we all know critical illness is very common and cuts across all specialties, and there is a substantial unmet need of critical care in our hospitals, and meaning that critical care has been neglected. And for real-world impact, all hospitals should prioritize the provision of low-cost, cost-effective EECC. So for us to be able to do this, we had to find out what evidence do we have around EECC, which I'm going to present to you today. We had a project called Poetic Project that we did quite a number of extensive work around EECC, and I'll also let you know about our future plans. So in the Poetic Project that we had, which went around COVID time, between 2020 and 2022, we investigated the optimal methods for providing quality care to critically ill patients. And this project ran between Tanzania and Kenya. We did policy analysis, we did surveys and questionnaires, interviews with healthcare workers and other stakeholders, and we also checked for cost effectiveness modeling, which I will share with you today. To understand the context of our work better, I'll present to you our conceptual framework. And as you can see it here, we have two arms. We have the identification stream and we have the care provision stream. So for us to to stabilize our patient, which is the outcome that we are looking for, we need to stabilize the patients who is critically ill. So for them to be stable, we need to provide them with effective coverage of ECC, as you see here in number 3. And for them to get this effective coverage, you first have to identify them, and then we have to give them the essential care. For us to be able to identify these patients, we need the structures that are essential for identification of these patients who are critically ill. And these are the requirements that Anna had showed before. Like, for example, if I have a patient who is hypoxic, I need to have a pulse oximeter that will show me this patient is hypoxic. And then we need the clinical processes, which are putting that pulse oximeter on the patient and being able to read the reading that is going to show, or maybe to show 80%, that will allow me to know that this patient is hypoxic. And then once I have identified this patient, I need to also have the structures, the hospital readiness, that will allow me to provide the care to this patient. For example, for this patient who is hypoxic, I will now need oxygen, I will need a face mask, I will need an oxygen cylinder, the tubings that will allow me to deliver this oxygen to the person who needs it. And then now I will need the clinical process. For the process now to happen, that means the healthcare provider will put the oxygen mask on the patient, will open the oxygen, and will allow the flow of the oxygen to the patient to happen. So once this has happened, it means that the patient is being provided with the care that they need. That means they're getting effective coverage, and they will be stabilized, and hopefully they will survive the critical illness. And further care can be provided after that. So from the projects that we did during Poetic 1, we had a number of findings, which were quite extensive, but I'll give you just a summary of what we found. For example, in Tanzanian hospitals, we found that around 85% of the resources that are required to provide ECC are available in our facilities. However, when you go to the ward level, the resources that are required for ECC are ready for use for critically ill patients are only at 57%. So the number goes down from 85% to 57% when you talk about readiness. What do we mean here? We mean these items might be available at the hospital, but when they're needed for the care of the patient, for example, a pulse oximeter might be available, but when it's needed to be put on the patient to check for hypoxia, then maybe it's closed somewhere because maybe it will get lost, or there are no batteries, maybe the probe is missing. So some things around readiness are not well taken care of. So it falls down from 85% to 57%. And we looked at advanced critical care. We only looked at availability of resources, and we found that this was quite low at around 32%. So it's quite hard to upscale advanced care, especially looking at the EECC itself is not up to standard yet. This diagram shows us what the findings were in 5 facilities that we visited. And green shows 100% readiness, which is what we require for ECC. Remember that we're talking about very basic things that each facility should have. These are not advanced requirements. They are very basic ECC requirements. We can see from this diagram, the district facilities are suffering quite a lot at red. That means below 50%. And human resource training, routines, and guidelines are also suffering at very low percentages. None of the facilities had any of the resources at 100%. There are no greens, as you can see in this diagram. And the other things that we found that there are large quality and safety challenges in critical care provision. In facility surveys, these are surveys like the SARA surveys done through WHO by Ministries of Health. when you look at these surveys, we might find that resources appear to be adequate. But when you look deeper into the system strength for ECC, it is not captured in these surveys. So they capture just availability of resources, but they don't really look into readiness of these facilities. And then we also have a lot of training and procurement of equipment, but these are necessary, but they're not usually sufficient as an overall solution. We know that trainings occur sporadically, and they're all usually based on achieving short-term goals, like improving specific knowledge and skills. And these don't address the environment the staff are working in. So sometimes we equip our staff with knowledge, but when they go back to their facilities, they don't have the other requirements that are needed for them to be able to utilize the knowledge that we have provided them with. So they actually, we create people who are more, frustrated because now they know what to do, but they're not able to do what they're supposed to be doing. Additional equipment may not make a long-term difference because, like for us to be able to, for this equipment to have a long-term effect, they need to be working and they need to be maintained. So sometimes we see that we have a lot of oxygen delivery equipment that are not working effectively because of the maintenance system that are not really in place. The systems of care remain almost as vulnerable to the next public health emergency as it was found before the start of COVID. So a lot of work has been done, but there is still a lot of work that needs to be done to make sure that we are ready if anything else is to happen. And coordinated care of critical illness is needed throughout hospitals and in the healthcare system so as to be able to take good care of the critically ill patients. The other finding that we had from this poetic project was we looked at cost and cost effectiveness of EECC. So providing EECC to critically ill patients costs around $17 to $21 per day. This was versus advanced critical care, which we also use a model of a hospital in Tanzania, which was around more than $200. We know that this is also not as high as it is in many places in the world or in very, very highly specialized ICUs. And it was also seen that the EECC to be very cost effective. If you look at this diagram, we can see EECC lies at a similar level with malaria treatment and emergency obstetric care, showing that it's really cost effective. It's a really cost effective intervention that is worthwhile to be made in our facilities. So can EECC intervention improve outcomes? Is there any evidence around that? So far, we had the vital signs directed therapy, which was done by Dr. Tim Baker and colleagues from Muhimbili University. And in this, they implemented the vital sign therapy protocol at the ICUs in Muhimbili National Hospital. And from this study, they found that acute treatment of danger signs increased from 23% to 73%, and mortality for hypertensive patients was reduced from 92 to 69%, so which was quite significant. So implementing EECC has the potential of improving patient outcomes. So where can EECC be useful to us? So EECC can be useful in improving care and outcomes of critically ill patients in our general wards, for example. So we get patients coming in from the emergency department, we get patients coming in from surgery. And these patients need to be optimized pre and post-op. And also we get patients who have infectious diseases, NCDs, and maternal conditions. All these patients can be stabilized using EECC, and their outcomes can be improved. We can also improve the impact of the scaling up of ICUs that is happening all over the world right now, including here in Tanzania. Post-COVID, a lot of initiatives have been put into scaling up ICUs and emergency departments. So what we see is that if you want our ICUs that you're putting up to work well, we need ECC to be in place in our wards and in our emergency departments so that our ICUs can work optimally. We can stabilize the patients who are critically ill. Some of them might not even require ICU. Right now, patients are being rushed to ICUs, for example, in some places just because they need oxygen, for example. But this is, we know that patients can receive oxygen in the ward. Sometimes they're just being rushed because they don't have, fluids or things like that, for example, or we don't have somebody who has the knowledge to, stabilize this patient. So if we implement ECC in the wards, that means we can stabilize these patients, and the number of patients who will require ICU care will reduce. Only those who really need it, who really need the care that is provided in ICUs will go to ICUs, meaning that our ICUs will work more effectively. And also, when we are sending these patients to ICU, we will stabilize them and they will arrive there in a better condition. Sometimes those of us work in ICUs, we know that we receive patients coming from the ward who are in their gasping stage, and we don't like that. Nobody likes that. So, but if ECC is in place in the wards, it means that our patients will be stabilized in the wards and they will come to us in a more stable condition. And it's also, it should be providing quality step-down care to improve post-ICU outcomes. So sometimes we also see that we have taken very good care of patients in our ICUs, but we're reluctant to send them to the wards because we're scared when they go back to the ward, the care there is not so good and our patients won't fare well. But if we are able to provide ECC in our wards, it means that our patients will be, we won't have those fears. We can, the patient can step down from the ICUs to the wards without any fear of them deteriorating. And this diagram that you see down there, what we're seeing right now, we have ICUs and wards which have maybe our quality is not so good. And there's a lot of effort in improving ICU care in terms of quality, but the wards are being neglected right now. No one is talking about the other wards. So it means there's a big gap, quality gap that's going to be created here if we go the way we are going right now. So there is a need to for us to get better outcomes. There's a need for the wards also to be scaled up so that together with ICUs, the outcomes of our patients will improve from the wards and also from the ICUs. Where else can ECC be useful? It can also be useful in optimizing the impact of scaling up oxygen. We know also that there's a massive oxygen scale up. In Tanzania, we do have that, and I'm sure and all over the world, there's a massive scale up of oxygen post-COVID. And ECC includes oxygen therapy for all critically ill patients. So we can look at ECC as oxygen plus. If we just provide oxygen to our patients, or if we just provide oxygen to our facilities, but we don't look at the patient holistically as a patient who also needs fluids, as a patient who might also need positioning and all the other care that is around their vitals, then we might also end up failing. So we also have to make sure that these providers or facilities are ready to provide ECC together with the oxygen so that our scaling up of oxygen becomes meaningful. And then it is also very useful for pandemic and emergency preparedness. We have had surges of critical illness, like we saw back in 2021 in India. So if our systems were ready for providing good ECC, we only need to scale up rather than introduce ECC from the start. So it will be very good if our hospitals or our facilities are ready with ECC, and it should be very easy if it's in our system to just scale this up to meet any surges that might occur. ECC is, along with public health and surveillance, an essential part of health system preparedness. So we have to be ready when we're looking at public health and we're looking at surveillance. ECC has to be part and parcel of this health system preparedness. What are the benefits of programs focusing on ECC? We see it's, as we can see, it's a low cost and cost-effective approach. to a huge quality gap. It's a very low hanging fruit and has a potential for large survival gains. And with this approach, no patient group is left behind. It's cross-cutting, it's time-critical care. Time-critical care needs of patients are prioritized. So it doesn't matter which specialty the patient is from, whatever their age is, it cuts across all critically ill patients, so no patient is left behind. And it also increases collaboration between disciplines and programs. So we see that sometimes we have providers being taken in for certain programs, like say CMOG, ETAT, and we know that in our facilities there's a lot of rotation of staff. So it becomes very difficult for staff who have worked, let's say, in obstetric to now start working in trauma because they didn't get that kind of training. But ECC cuts across all specialties. So whatever the healthcare provider is working, whatever they're working, if they're moved to another specialty, they'll be able to cope. And as we said before, it will improve effectiveness of advanced critical care. And as we know that we're upscaling this right now, for us to really do well in making sure that our patients get good advanced critical care, we must first ensure that essential emergency and critical care is in place in our facilities. It also reduces qualitative skill shortages because we can do task sharing, and the healthcare workers become resilient to rotations, as I said before. It also there's increased preparedness for public health emergencies when ECC is in place. So what are we doing now what we're doing in the future? Right now, we have the eccnetwork.org. Please join our network. It is open to everyone who is interested in essential emergency and critical care. It's really growing quickly, and majority of our more than 400 members are from the lower and middle income countries. Right now, we have the Poetic Africa project, which aims at improved understanding of the burden of critical illness and effective coverage of ECC in African hospitals. We are going to run a project similar to ASOS across Africa that will look at the burden of critical illness, and this will happen soon. We're looking also into bottlenecks analysis and the drivers of these bottlenecks. We're also going to be looking into context appropriate intervention studies, looking at patient outcomes, processes, system effects, and economic analysis. And we're also currently doing a lot of advocacy and involved in many global and national COVID responses and pandemic preparedness globally and nationally. And we're also looking into implementation of EECC and training. Anna is leading the training task force or working group within the EECC network. So we're looking into all these parts of EECC currently, and future work lies in making sure all these things happen. EECC has been growing quite a lot in the last 2 years, and we're really happy that a lot of people have seen the importance of EECC, and we need more people to understand this concept and implement it in their facilities, in their nations, in their countries, and globally. So our take-home messages are that critical care is neglected and it should be looked into. We should prioritize ensuring that essentials are always in place, meaning that ECC is always in place. There are large gaps in ECC coverage, as we have seen from Anna's work and our work that we've done with Poetic project. And ECC is a low cost and cost effective and has a large potential for averting deaths. Thank you very much. And this marks the end of our presentation. Please join our network again. It's eccnetwork.org. Thank you.
Wow, thank you so much, Anna. Thank you so much, Karima. I'm sure a lot of the participants are nodding their heads, realizing, wow, these are things that we have thought about and thinking of how to address them. Just a brief summary on what we've been discussing for about 45 minutes, and with Anna starting off, explaining what EECC is about as care that all critically ill patients should receive in all hospitals in the world. And she talked a bit about what critical illness is and how it's a very severe illness. And of course, we understand the burden of critical illness and how it puts a lot on the resources. The fact that not all patients, we all realize, will be able to be admitted into the ICU and HDU, and why EECC is of utmost importance, how essential it is, just like the WHO drug essential drug list is, and how it is important that it should be available at the lowest level of care in all units in the hospital. And we all realize that critical resources will vary based on the settings, is it on the ward or in the ICU, the status of the hospital, or the time of the day, night or day, and how, like she says again, EECC is quite essential. It has clinical processes and hospital readiness. They need to have essential facilities with staffing and training of this staffing to be able to recognize the critically ill patients and care for them going through the ABCD analysis. And of course, any new intervention, we try to think, what's the cost effectiveness? And of course, if you're going to do this at the basic level in all wards, labor ward, A&E, general surgical wards, the cost effectiveness, of course, cannot be overemphasized. We know how much critical care is, admissions in ICU and the cost. And in places like in Nigeria, where ICU admission and payment is out of pocket, of course, we'll be doing a lot for the patients and their relatives if this essential critical care can be available on the ward, and probably reduce the admission into the ICU. Karima really went on to talk about the concept and the framework, like patient identification, the essential equipment and coverage. Talking about the poetic study which she did, which is provision of essential treatment in critical care, I think brought to fore that some of these resources may be available on the wards, but when needed, not as much. Either they're kept by the head of the units in some places that are not accessible out of during call hours or weekends, or probably they're probably not even trained on how to do that. She talked about the cost effectiveness, and I think the important thing is to strengthen the systems on the wards and out of the ICU, and the usefulness of the EECC, because it improves care and outcome of the critical ill patients in the wards, improves outcome in the perioperative period, and also it helps in identifying critically ill patients early on in the wards, and probably instituting treatment will actually de-escalate them coming to the ICU. It could also help to stabilize these ill patients so that when they arrive into the ICU, they are not as severe as they should be. And of course, quality step down of care when you move the patients out of the ICU to the ward. So I think in the last 45 minutes, we've really realized how much essential this is, especially where we know ICU beds cannot cater at all for all the ill patients in the ward. At least COVID has taught us that. We have some, so please put your questions in the comment box. Thanks a lot, Anna and Karima. And I think they've also put in the EECC network link for people to join in. There are some questions in the chat box. I think some have been answered. So we have one from Fred Fly. This is addressed to Karima. How have hospital staff received this intervention in hospitals in Tanzania, where EECC has been implemented?
Thank you, Fred Fly, for this good question. We haven't yet implemented any EECC intervention yet in Tanzania. We are yet to start that. We had a strategic plan that has been developed through our work, and currently we are looking into implementation phase of using that strategic plan by the ministry, because we can't implement anything without the ministry agreeing to it. So now that we have the plan, we are ready to start implementation. And we are going to look into several implementation ways, several ways of implementing ECC in different facilities and seeing what will work best. So yeah, the question will be answered after I can give you a good answer after we've done the implementation. Right. Thank you.
Okay, thanks a lot. To Anna, I think Dr. Job had written something there and said, is this will this EECC be provided in a different kind of ward or to a different set of people?
Yeah, I think that Karima answered that question very well, and that EECC is across the entire system. And if you think about the interventions that the care processes and the hospital readiness that we mention in EECC, it's in fact the things that should be there already. When a patient is sick and presents to the hospital, they assume that they will have their vital signs checked and that they will have a history and physical taken. And they assume that if their vital signs are abnormal, that they will be sent to an appropriate place and that a care plan will be developed to address their illness. So if you think about EECC, it's really what should be happening everywhere anyway. So it's more of a systems innovation and a way of thinking. It's not necessarily a new a new way of doing things. It's really what should be happening in all hospitals around the world. The problem is it's not happening. So that's what we're trying to address, is to make sure that the essentials and fundamentals are available to all patients.
Thank you so much.
It goes across specialties, it goes across wards, it goes across patients, it goes across locations. It's everywhere.
Okay, thank you very much. We have a raised hand, Professor Bibioshi Naike. He's the president of the Critical Care Society of Nigeria. Please, you can ask your question. Thank you.
Thank you, Dr. Irene. Thank you, Anna, for that great presentation. And Karima, also, thank you so much. I love what Anna just mentioned now, that this is not a new thing, but it's something that should be happening, but it's not really happening. And that is why I want us to, this is my comment, I want us to consider it. And that is, most of these issues we are talking about are related to poor government policies with relation to health. All over Africa, we know that either because of poverty or maladministration, we have issues with health. And not just critical care, generally health policies are faulty and most of the health systems are not doing well. And that is why we are where we are in Africa especially. So I want to ask and find out from Anna, what are you doing, or what are we doing, because I'm also a member of the network, what are we doing to ensure that advocacy, we have strong advocacy to the World Health Organization, to African Union, and even to different governments, in Africa, so that they can adopt this and make it a universal policy for health administration in Africa, especially. Because I think this is what we need. Individual hospitals may not be able to really do this. Most of the time, the policies are faulty, and we need to address this from the WHO, from the government, from African Union perspective, and I think this is going to help us. And finally, I don't know how much we are doing as per determining the readiness, hospital readiness all over Africa, not just isolated. If we have data on hospital readiness all over Africa, we can use this even to push, our point with African Union or WHO to force government to put policies in place that can actually ensure that these basic things are available in our hospitals. Thank you very much.
Thank you for the excellent question. And I think you are 100% correct. And healthcare systems are incredibly complicated, and there are many pieces to the puzzle. One of the pieces is we need good governance and we need advocacy. We need that coming from the top, from the middle, and from the bottom. A couple things have happened recently. At the most recent World Health Assembly, there were a couple resolutions adopted, one sponsored by over 80 member states, prioritized the strengthening of health systems in order to provide better emergency, operative, and critical care. And for those of you who follow what the WHO does, this is really the first time we've heard critical care being prioritized. So much like global surgery was prioritized in 2015, we're starting to now see that people are recognizing that critical care has been under prioritized and that it does affect all patients everywhere. Another part of the healthcare system that you mentioned is infrastructure. And that is a problem in many places, even in high-income countries, where we have a lack of investment from our own governments in the infrastructure needed to provide the best possible care for our patients. Another key portion of healthcare and healthcare delivery to our patients is education and training of our providers. Additionally, we need to have providers that are compensated well and have a good work-life balance, as some say. And so there are a lot of things that need to be addressed, and these need to be addressed simultaneously in order to increase the quality of care that we can deliver to our patients. So as a network of EECC folks, we're trying to address all of these things from education and training to providing the research that demonstrates the value of EECC, and then also involved at the level of advocacy at the top, in the middle, and at the bottom. So we're certainly aware of the complexities and are trying to address all of them.
Thank you very much, Anna. We'll just take two more questions and would ask that you be a bit brief. So I'll call Dr. Panda next. You can unmute
Good evening, all. Thank you very much for considering me. Actually, I can see the value of this EECC. It's like the noble land in medical practice generally. If you look at what patients lack in most of the facilities is this emergency critical care. So my own concern is, how do we now incorporate it into the practice? Because actually there's need for training from medical school and residency, and also in nursing training and post-basic training of the nurses. Because it covers all the health practice, all the professionals are involved. So actually there is need for serious coordination, because this is what really patients need in our facilities globally. Because if a patient will have this emergency critical care, his chance of surviving and getting out of his problem is very high. So I think now it is very important for us to look at how do we involve other professionals, and who is supposed to champion this issue. Is a very important and sensitive issue. And looking at into consideration, the management can provide facilities, and the people that are supposed to provide it might not know how to use it, or they don't know how to operate it, or the management might not provide the facilities. So actually, it's a very important issues. That's my own take home. Thank you very much.
Okay, thanks a lot. Anna, we'll just get all the questions so we can respond once. And we have Dr. Jude Mbemena. Please briefly unmute yourself and ask the question. Please brief.
Good evening, NSA and participants. I'm Dr. Jude Mbemena from Ozobolo, Anambra State, Nigeria. I'm a community physician and I practice in my village. We are too institutionalized. We always focus on institution, on who will bring this and who will bring that. No. From my practice and my community, I've learned a lot that what we have is enough for us to educate the neighborhood of all we need. We are always focusing on what the government can do. No, we can do it. When the politicians are smart, when they see you organizing some of these things in the communities, in your district, we call it, in my language, we call it Omonna and Co. When you organize those things, they will come because they want to win the next election. They will call you. So I'm trying to remove the focus on training doctors. Let us make a little of a doctor on every person in life. Because when emergencies come that will turn out to be critically ill, they don't need to wait for you to be a professor, a genius, for you to see that case. You might be a little child.
Okay. Hello, Dr. Jude.
Being healthy. So I think that this EEC is important. And I thank you for encouraging us, especially those of us that are practicing privately in our local area. Thank you,
Okay.
and God bless us.
Thanks a lot. I will just take one hand raised, Dr. Papicho, because he's from Zambia. Dr. Papicho, please, could you unmute and accept? Dr. Papicho, yes.
Thank you very much, Irene, for the opportunity you give me to speak on this important forum. And my question is going to be addressed to Karima. And before I go straight to Karima, I would like to thank the two presenters for the great presentation that they did. It's really taking us awake and giving us some work to do on the ground. Karima, I know that you've done a lot of work on the EEC. We want to get your experience and then so that it can help us also follow suit in the implementation of the EEC in different regions in Africa. So could you share the strategic plan that you have after you did your background work so that we don't remain far away behind, otherwise that will not be felt in Africa, so that we all move on the same speed. Thank you.
Thank you very much, Papicho. I think, Anna, if you can could briefly answer those questions. Well, I think if there are some that can be answered in the chat box, Karima can answer those. There's still a question there, but I'll allow Anna answer before we respond to Dr. Naji's question.
Papicho's question was for Karima.
Oh, okay.
Yeah, thank you so much, Papicho, for that very good question. Currently, what we have done is the assessment of facilities here in Tanzania, and there's also some work that has been done in Kenya. But we do have people who have reached out from different countries like Ghana, we have Malawi and other areas that have wanted to do the same similar work in their countries, and we have been working with them towards doing that. But the aim is to be able to do, Africa-wide assessments, and that is also going to be happening very soon. We're doing the Poetic Africa project, and some people even in this group are involved, like Fred is within that project. So we will be doing something that is will give us a better picture. So please, if you're approached from your different countries to do this, we know that this work needs champions, people to do to drive this work in their countries, so that you can get good evidence from Africa. This will be happening quite soon. So let's participate in that. It will give us a good picture of where we are in terms of the burden and where we are in terms of how the critical care or essential emergency critical care is in our facilities in Africa. And anytime you have anybody needs to do anything within their countries or their regions or their governments, then they can reach us through the network, and we will be able to assist in making sure that whatever is needed can be done. I think briefly that's what I can say for now. Yeah.
Okay, Dr. Chima's question is on what's the strategic plan in achieving EECC in Nigeria, where he says the anesthetist has relative or no influence in other essential areas of the hospital, and the nurses, taking into consideration the limited staff strength. I think with experience and working with EECC, the fact is, as anesthetists in the hospital, we are key in a lot of places in the hospital. Oxygen administration on the ward, teaching of the staff on escalating oxygen therapy. I think it might be a burden on us, but I think we may need to do that. in teaching and training, and ensuring that our wards have monitors for vital signs monitoring. We monitor a lot of patients, and it's something we as anesthetists and intensivists in our hospitals can advocate to the hospital management to have these equipments on the ward, because having them on the ward, then you're able to teach the nurses and they can properly triage patients and have the care plan to be needed. It's a lot to be done, but I think we have a lot of influence in these essential areas, because when patients go down, the tendency is to call us. So we can mitigate that by ensuring these are there. So there's really no need to escalate, or as ECC usefulness is if they have to escalate, then the patient should come to us in the ICU in a relatively stable state. I don't know if I've answered that. There are more questions. I don't know if there's anyone we haven't answered. Anna has said ECC is not ICK, it's fundamental and basic, and I think it's we need to make that care available on the ward. I think we've spent quite a lot of time, so I'd like to hand over back to the chair of the NSA Education Committee, Dr. Al-Hassan Dati Mohammed. And before I finally hand over, I would like to really thank the President NSA, Dr. Bisola Briggs, and the chair of the Education Committee for choosing me as a moderator for this session, which I'm really quite passionate about. Also, thanks to the BOT executive and members of the NSA for this wonderful webinar session. So I'd like to hand over to the chair of the Educational Committee, Dr. Dati. Thank you very much.
Thank you very much, Irene, and thank you, Anna Crawford and Karima Kali for responding to our request. It's been a wonderful I've seen the question raised by the President, Intensive and Critical Care Society of Nigeria, Professor, sorry, he raised a question that should be incorporated into our policies. Now, the first step is for all of us to join this EECC network. And then our voices will be heard and we'll plan together. Okay, so thank you very much. The President NSA, you're around. You want?
Yes, thank you very much to everyone present here today, starting from our speakers,
okay,
Anna and Karima. I must say, this is a very needful one that has been neglected for some time, and we need to run with it. I want to lend my voice to others who have contributed to this. We need to run with this vision. It's like, oh, we've been missing something for a long time. We need to blow the trumpet more to various areas. And I'm just thinking of the National Surgical Obstetric and Anesthesia and Nursing Plan. This is also an area that has to be carried along in this vision, because since already, we have other groups in this system. So I think this is a very good one you have dropped into our hearts today in the Nigerian system. And I must say that we will not rest with it. We will announce this more in our various localities. I want to say that as different anesthetists that we are presented here today, we should please go. And yes, I can see that end source must include EECC. Yes, yes, yes. But I saw that, Anna, so we have to, spread it more. I think this involves both us and the government. Somebody said the government is not involved in this. No, we need advocacy. We need the government, to also help us with those pertinent instructions, because we're also going to be dealing with the nurses, and from our experience, we know they are peculiar people that we have to also identify with some strategic approach. So we need the cooperation of everyone. So without wasting time, I think this is a very good eye-opening session we have had, and we're going to run with it. I can assure you. We need to spread it to every corner of Africa. I am also putting my approval to the Africa-wide project. So let's do that too and get involved, just like we've had with other ASOS. So thank you to every one of you. Thank you, moderator. You've done very well. Thank you, my one and only chair education committee, Professor Dati, and thank you to the technical team, and thank you to every one of you who has taken time out. I can see some other participants from other African countries. We appreciate you all. Thank you so much for being here, and I believe together we will achieve more as an African team. Thank you, and goodbye, everyone. In the absence of any other thing, I think the announcements are explicit on the platforms for the various programs we have in the association and our dues. So thank you once again, every one of you. And have a lovely weekend. Bye.
Bye too.
Thank you. Bye.
Thank you. Bye.
Thank you. Bye-bye.
Thank you.
Bye. Anna,
Bye-bye.
thank you.
Thank you, everyone, for joining. Thank you.